دكتور سامح مساء الخير.
نور دكتور محمد، اهلا وسهلا. ازي حضرتك؟ ايه الاخبار؟
عاش من شافك، شو اخبارك؟ ان شاء الله بخير.
عيش ربنا يكرمك. الحمد لله كله بخير والله، ماشي الحال.
دكتور هنيدي, how are you? Nice to see you.
Hello everybody.
دكتور حياة, hello.
Yes, I'm there. How is everybody?
Yes.
الحمد لله fine. Nice to meet you, Dr. Hayat.
Pleasure, Dr. Sameh.
Thank you.
Dr. Sameh, you are the moderator of the session, so please you can start the session as usual. I think all available except one. We will just have it soon. So the mic with you and the floor with you, please, Dr. Sameh. Thank you.
Okay, thank you very much, Dr. Muhammad. It's my deep pleasure and honor to participate in this session. I remember well when I attended the first week. It was 8 years back. And I met Dr. Muhammad and we prepared well, I think. It was a very successful, prestigious meeting. And
you are the one who prepared the scientific program, by the way. Thank you very much.
Thank you very much. It's my pleasure and honor. Today, I'm happy meeting some old and new friends to start a pediatric session. Hopefully, it will be fine and you'll enjoy our scientific program. And I think we have to invite our first speaker, Dr. Dylan, for novel treatment approaches for amblyopia.
Yeah, thank you. I'll share my screen now and then you can I'll start my talk. Okay, I think you can see my screen now.
We can see it well, Doctor. Thank you.
So I'm going to start. I'm going to start with dioptics and the treatment of amblyopia. This is the newest topic in the treatment of amblyopia. As we know, amblyopia is really a monocular problem, as it was thought it was maybe 10 years back. So it's not really a monocular issue. Amblyopia is a developmental disorder of the visual cortex that arises from abnormal interaction, be it strabismus, be it anisometropia, anything that occurs in the difference in the visual perception from the both eyes in early childhood, leading to cortical suppression of the amblyopic eye. So it is basically imbalance in the intraocular supply that favors the dominant eye, leading to decrease in the visual acuity. So the binocular functions are impaired, such as impaired stereo acuity. But the modern concept is that we need to look just beyond the visual acuity. Visual acuity is not everything. So the conventional therapy of amblyopia included patching or penalization or pharmacological penalization or mechanical penalization, which has been proven effective for children less than 6 years of age. So the amblyopia treatment studies conducted by the pediatric groups, they say that about 120 hours of patching can improve the visual acuity by 1 line in children who are 3 to 8 years of age, and the effectiveness decreases steeply with age. It's not always successful. It is not always seen to be successful in hyperopic anisometropic cases. Yes, it is successful in myopic anisometropic cases, to some extent successful in strabismic amblyopic cases as well, but there are compliance issues, there are recurrence issues, and it does not directly address the interocular inhibition. Dioptics, on the other hand, is based on the push-pull protocol that recalibrates the interocular balance of the excitatory and the inhibitory interactions. So the push element, it excitants the weak eye, and the pull element, it inhibits the strong eye's perception. What really is dioptics? So dioptics, as you see here in the picture, there are two kind of picture illusions that are given to the eye. The dioptic training reduces contrast to the fellow eye to rebalance the contrast within the two eyes. It promotes the treatment of amblyopia by promoting binocular vision. It reduces inhibitory interactions in the visual cortex, and it decreases the suppression and improves the stereo acuity as well. It forces both eyes to work together. It forces the brain to interpret the reaction from both eyes together, and therefore increasing stereo acuity in addition to increasing the visual acuity in the weaker eye. So a lot of studies in the recent times have been conducted. A study conducted recently in 2015 in China stated that there has been a visual acuity improvement of 0.15 logmar, which has been clinically significant, and 0.06 logmar compared to the patching group. The stereo acuity improved by 43% in the non-patching group compared to in the patching group compared to 34% in the non-patching group, and there has been reported improved contrast sensitivity as well. Recently published in 2019 in the American Academy, there has been a randomized controlled trial of dichoptic and digital therapy for amblyopia by Scott et al. And they say that at 12 weeks, amblyopic eye visual acuity improved by 1.8 lines in the treatment group compared to 0.8 lines in the comparison group. Travi et al. Also suggested that dichoptic treatment of amblyopia led to a mean improvement in visual acuity by approximately 0.33 logmar, which has been visually significant. That is Snellen's visual acuity 20 by 63 to 20 by 32. And there has been reported a statistically significant decrease in suppression. Dichoptics is not just video games. There are also dichoptic movies coming in, recently published in JPOS in 2015. A dichoptic movie treating childhood amblyopia by Simon et al. Says that the visual acuity improved significantly, approximately 2 lines at the last outcome visit. So dichoptics is not just used for treating childhood amblyopia, it has been seen to treat adult amblyopia as well. This is the unique selling point of dichoptics. It has been noted that adults do not respond to conventional occlusion therapy, but it has been seen that the adults also have a significant degree of plasticity. Published in 2021, dichoptic training does enable adult amblyopic brain to learn as well. So significant improvement in visual acuity, specifically significant improvement in stereo acuity has been noted in both groups. And the stereo acuity has been greater than by a factor of 4. 2015, again, Indu Vedamurthy in India did see that there was improvement on an average in about 27% of the children who were treated with dichoptic games. And there was improvement in the stereo acuity. In addition, there was improvement in the reading speed and contrast sensitivity. Amblyopic therapy with dichoptics in adults, also using an AR headset, also resulted in improved visual acuity from 0.58 logmar post-training, pre-training to 0.43 logmar post-training, with also an increased change in stereo acuity. So the newer concept that has come in is that we've always believed that the fellow eye of the amblyopic eye is normal. However, the recent concept says also from the histopathological changes, we know that the fellow eyes are also not normal in amblyopes. They do have oculomotor, visual, and visuomotor deficits in the fellow eye, as in monocular as well as binocular function. So dichoptics has been an effective therapy to improve the binocular vision in the better eye as well as in the amblyopic eye. It has been seen in a recent article in 2020, it has been seen that when they were evaluating the acute effect of stereoscopic recovery by dichoptic stimulation, they recorded the electroencephalogram waves in the brain as well, and they saw that by dichoptic stimulation, there was stimulation of the beta waves in the brain as well. There was significant difference in the beta power spectral density in the primary visual cortex, and there was also significant difference in the middle temporal lobe region, where the specific region of the dorsal extrastriate processing stream was there, which led to a higher change in the mean visual acuity at follow-up, also a higher change in stereo acuity. So we need to also start thinking beyond visual acuity and beyond stereo acuity. In smaller children, younger children, we do need to focus on a holistic improvement in behavior, including visual behavior, which includes motor functions, fine motor skills, including manual dexterity. Very recently published in February 2023, we have this study that was published in JPOS by Birch et al. Saying that binocular amblyopia treatment, it does improve manual dexterity and manual dexterity skills in children, such as playing blocks, threading beads into a needle, or threading beads into a necklace. And children who have been playing video games with both hands, children have been seen to be more ambidextrous after 4 to 8 weeks of binocular amblyopia therapy in the younger as well as older age group, which when compared to age-matched controls were statistically significant. So I would like to conclude by saying that dichoptic training can improve and even restore stereo acuity in children with amblyopia, especially those with mild to moderate amblyopia. And we used to treat strabismus prior to strabismus. The only drawback here is that we need to treat strabismus before starting dichoptic therapy because it is a binocular vision therapy. So in cases of strabismic amblyopia, the child actually needs to go strabismus surgery first and needs to be corrected within 8 to 10 prism diopters. There are better results seen in anisometropic amblyopia compared to stimulus deprivation amblyopia. It is the way forward for management of adult amblyopia and younger children. It may not be very effective in younger children as they don't understand the game settings. So a combined approach with patching may be considered in the younger age group, less than 6 years of age. Thank you.
Actually, it's a very nice talk. Thank you very much. But I'd like to ask you a question about studies, because you mentioned it's much better in anisometropic amblyopia. But what about using different types of treatment of amblyopia, like in dichoptic training versus patching, according to the different types, like in after visual deprivation amblyopia or
I agree with you. So in my personal experience and also in terms of the literature that is available, in visual deprivation amblyopia, to be very honest, none of the treatments seem to work very well. Like, we do not expect the visual acuity to be, we don't expect 100% recovery in the amblyopic eye. In those cases, I think patching would be actually a better option initially to bring the visual acuity to a level where the child can actually understand what a dichoptic is. So if a child is, say, finger counting vision or say 660 vision, we do need to encourage aggressive patching to bring the child's visual acuity to maybe say 636, 618 to about a moderate amblyopia activity. And then we can try dichoptics for that child. Even if it doesn't improve the visual acuity at that stage, it does seem to improve the stereo acuity quite as well.
Okay.
Yeah.
Thank you very much for thanks again for this nice presentation. And now it's turn to invite Dr. Hayat Khan to tell us what's going on regarding myopia, progressive myopia, and he will tell us the management of myopia progression, current strategies. Welcome, Dr. Hayat.
Thank you very much, my friend, Dr. Jalal. Thank you, Qasimi Group and Dr. Amri for giving me this opportunity to make this presentation in front of the esteemed audience. So let me just see if my screen can be shared. I don't know if it, can you guys see?
Not yet.
So I think I'll have to do it the other way around. So share screen one more time. Are you able to see?
Yeah. Now fine.
Thank you very much. So I think I'll have to minimize this part. Okay. So we are living in an age where there is a huge number of patients coming to especially pediatric eye clinic with problems of myopia, that is short-sightedness increasing over a period of time. I see patients, they start with very small numbers, and within years you see them going at a huge pace. So globally, this has become a pandemic, and global prevalence, as you can see, myopia as such is about 30%, and we look at by the year 2050 growing to more than half of the world population. Having said that, the number of people having more than -5 or -6 will be more than 1 billion people. So this is a pandemic. So I'm not going into the detail as what happened in pandemic and how the schools have adapted the near devices and what implication it had. But definitely we have seen since the year 2019 and 20, there is an increase in the progression of myopia in school or children's. If you see between 6 to 13 years, this study, you can see the graphs. There is an exponential increase in the after the home confinement, and following which, if you see, even this data came out, which was quite revealing as how the myopia increased over in the last few years, let's from 2020 onwards. Now, I'm not going into these busy slides, but I can definitely say there is some amount of evidence which now we are very confident that smartphones near time, especially kids bringing the devices very close to our faces, having a direct implication in the increase in the myopia. That is the way behaviorally we are modifying our structures of the eye. So the question here is, how do we manage this pandemic? That's the question that I have to ask. So if we go to first, I will go one by one different strategies. First, I'm going on to the contact lens, where I would like to talk about the Blink randomized clinical trial, in which we found clearly that if we are able to have a peripheral rays defocus in front of the peripheral retina, we can contain the myopia. And that has shown to be beneficial in improving the myopia. So the peripheral light rays further focus in front of the peripheral retina if we use these contact lenses, which we give an add of a +3. So that strategy has worked pretty well, and there are very good results which are coming with this soft multifocal contact lenses with high power to slowing the progression. And we found this has come to as a good way in which we can get around. Now, myopia treatment, if I put it all together, can be divided into 5 or 6 different categories. So I'll go quickly one by one. The pharmaceutical category, in which we are talking about atropine. This is the mainstay of treatment at the moment that we are using on a daily basis in our clinics. Pyrazipine and 5-methyl-xanthine can be another strategy, but still under investigation. The results have not been still that confirmative. So for now, atropine is, I'm going to go into detail later, but atropine pharmaceutical therapy children with growing myopia is there. In terms of opticals, we can give spectacles, in which, of course, undercorrection of myopia, a lot of people thought that that can improve, but it came out, no, it does not improve myopia. So we should always give the full correction. Peripheral myopic defocus, progressive additive lens, which I had just discussed with the Blink study, and then executive bifocal base lenses. All these glasses and contact lenses, these are the mainstay. So of course, the soft bifocal dual focus lenses, and lastly, of course, the ortho-K lenses, they are very important. So progressive add lenses in glasses, PAL, and bifocal contact lenses with an add of a +3. Both of these strategies have improved the chances of children not growing the myopia by up to 50%. Okay, so spectacles and contact lenses, both are there, different brands, different. There is, of course, this DIMS technology, which is there, which has also very promising results. As you can see, these are glasses There are different, I'm not taking the name, but there are the different brands which are there. Some of them are not available at the moment in Dubai. We are trying very hard to get them. Some of them are there, and we can use these glasses, and they have some kind stellate little areas of peripheral defocus, which can bring it anteriorly and have found to be very effective. Going on to the environmental factors, very important. So of course, from Dubai context, it is a little hot now, but otherwise, bringing the kids outdoor activity 2 to 4 hours a day can go a long way, especially daylight has found to be very important in controlling the myopia. So a lot of parents ask me, well, if the kids can keep on wearing sunshades all the time, I give them reservations. No, because especially if they're myopic kids, that can be a big problem. And lastly, the behavioral, that a lot of kids bring their the mobile devices so close to their faces that can actually give rise to increase in the myopia. Giving breaks every 20 minutes or 10 minutes, a break of 20-30 seconds where they look far. If they have nothing far, at least close their eyes and give relaxation to their eyes can also go in a long way. And lastly, the most important strategy which I use, that's a combination of all these strategies put together. So I may start a patient with a pharmaceutical treatment of atropine, 0.01%, let us say, and I keep these patients on a continuous monitoring. When I say monitoring, I'm talking about two things: their spherical equivalent myopia as well as their axial lens. So very important that we keep a look at our patient's axial lens. So let's say if somebody has an axial length of 25 at the start of the treatment, we have to see how it is progressing over a period of time. In certain cases where I would like to be pondering and doing a little more research, where I'm not having straightforward onwards, I will also be monitoring the corneal topographies. I may be monitoring their lens thickness also, because all these have a role in playing how emmetropization of eye happens. And wherever there is a defect in this process, that's where myopia increases. So as progression, usually the axial length elongation supersedes the other mechanism, and that's where you get it. Now, just to let all my audience know what is orthokeratology, these are lenses specially designed RGP lenses, which are worn overnight to reshape the cornea and thereby temporarily correct the low to moderate myopias. Now, we have changed this. Now I am having the ortho-K lenses, which can go up to not only myopia of spherical equivalent of 5, but even till minus 7.5. But of course, it takes a longer duration for these kids to go completely glasses free. Now, going on different medications, I'm not going in. We're looking at high dose of atropine related to all other different methods of controlling strategies. And these are older, different strategies which were in there, but out of these, not all the strategies were so helpful. And outdoor activities, as I talked, definitely a positive impact. Undercorrection and spectacle lenses, all of these did not really contribute much in decreasing the myopia. So going further in the effectiveness of myopia control, we also looked in different concentrations. And a lot of publications are available where we're looking at different concentrations: 0.01%, 0.02%, 0.05%. And we're looking at what are the help that we are able to get, and what will be the best concentration that can be effective. I'm not going much into the detail of ATOM2 studies and the LAMP study, where effectiveness of 0.01 atropine has been established, and importance of a long-term use of at least 3 years of these eye drops in children with practically very, very minimal side effects has established that as one of the key treatment strategies which we are using for now years in our clinic and here in Mediclinic Parkview hospitals. And we're looking at these studies. I'm not going into the details, the study, but of course, The study definitely came out and have given us a way in which we can treat our patients just with the eye drops every night, both eyes. Sometimes I combine this with use of ortho-K lenses, and in those cases, I'm asking the patients to use the drops in the morning, the atropine drops, and I combine to get a synergistic effect of treatment. Now, going further, we always have an algorithmic way in which we process our patients. We see the willingness of parents for the treatment. Once they have, we start them on atropine eye drops. We keep them on every 6 monthly monitoring, in which we look at their spherical equivalent refractive error as well as their axial length. If we get a good response, we would continue till about 12 years age, and then of course keep on tapering the number of how often we are following up these patients. And when of course we see that also when there is the children are 12 years, then of course we continue to monitor every year till we have the cessation of treatment. If these patients have a poor response, then we sometimes think about increasing the atropine dose from 0.01% to 0.02 or 0.05. But problem is, it's very difficult to get these different percentages of atropine eye drops. So you have to formulate it, and you have to have pharmacy, which should be helping you out in this. So now going further, there are different studies. Again, I'm not going much into the detail and doing the different comparison because of the constraint of time. In today's talk, it's only about 10 to 12 minutes, which I'm almost completing at the moment. So very important to inform about the axial length, that how the slowing of axial length is when we talk about ATOM studies, 2 years, LAMP study. And what we found is that 0.01%, we have to think if really it is the correct percentage to improve the progression of myopia. And then of course, when we talk about 1%, it is very effective, but there is a rebound phenomena which we do not want. So when it comes to the axial elongation, sometimes the effect of 0.01% drops have not been so improved as compared to the other concentrations. But that is the one which is at the moment freely available in our hospital, and we are using it, and we are pretty happy over the last 5 years that I've been using. So there are different studies. Of course, as you can see here, I'm not able to see the whole this thing. 1 minute. This is not coming. So there is the MOSAIC study, which is a double-blind, placebo-controlled, randomized trial in myopia progression in children. And what we found is that the myopia control, especially in the Asian ethnicity, this was looked in, and this is looking in how well the effectivity and the safety of this 0.01% drop is. And what they found was that the 0.01%, if it can be changed towards prescribing 0.025 or 0.05%, that will, of course, that will decrease the amount of shift in terms of the progression. So we can always look in the CooperVision MySight daily wear contact lenses. That can also be another option instead of ortho-K lenses. So in conclusion, in our practice, atropine eye drops along with orthokeratology or multifocal contact lenses are good. Patients where they are not able to use orthokeratology and multifocal contact lens due to age or due to their personal preferences, a good option is to give multi-PAL, that is the progressive glasses, can be there. Of course, a good amount of patient education, family education is key to have good results. And that will go a long way in decreasing the myopia. in the end, I would like to tell that most of the results for 0.01% eye drop usage have been very promising, coming out of different parts of the world. Thank you so much.
Thank you so much, Dr. Had Khan. It's a very nice, condensed, heavy meal. Thank you for this presentation. And now let's move to the person I do respect myself, Dr. Hassan Sabri. We didn't meet long ago, but it's a good chance to meet him again now to tell us what's about sixth nerve palsy.
Thank you very much, Dr. Sam. Do you hear me very well?
Yeah.
Okay.
Can you please start sharing your screen, Dr. Hassan? You'll find the icon down called share screen.
Okay. Share screen. Yes. Okay. Can you see it now?
Yes, now it's fine.
Okay. Clear. That's clear?
Very well.
Samah, is it clear? The screen is clear?
Yeah, very clear, Dr. Hassan.
Okay. I'm asked to talk about sixth cranial nerve palsy, abducens palsy. What I want to tell everybody that congenital abducens nerve palsy is rare. We have to keep that in mind. So when we have acquired case of incompetent dysotropia due to abducens nerve palsy, it's a challenge for the doctor and for the ophthalmologist because we want to know what happened. And management starts by first finding and treating the cause. I'll show here 4 cases. This slide will show the pathway of the abducens nerve from its origin at the nucleus in the bones, going out through the pontomedullary junction, over the petrous bone, through the Dorello canal, and then through the cavernous sinus, superior orbital fissure, annulus of Zen to the muscle. It's a long way. That's why it's very susceptible to trauma and bruising, and that's why it's affected in most of the trauma cases. Case number 1 here, it's a child which is 4 years old, sudden onset of right eye crossing since 3 days only, and he was heavy user of smartphone. He was mentioned in the history that he was sliding on a slippery floor a week earlier and vomited and complained of mild headache. His vision was fine, and as you can see in the video here, that he has limitation of abduction in the right and left eye, and up gaze, down gaze, he was normal. This is the optic disc, which shows subtle edema, but when you do OCT, it shows definitely that he has started optic disc edema. So history of trauma with vomiting, headache, sudden onset of incompetent dysotropia, possible diplopia, mild bilateral abducens nerve weakness, optic disc swelling. What's next to do is definitely MRI on neuroimaging. And the result came that he has abnormal MRI. There was a hematoma inside. And from that point, neurosurgical interference is a must. So traumatic sixth nerve palsy is very important to consider in a child who's having abducens palsy. Don't think it's congenital. And as I said, the trauma is due to that the nerve is tethered at the Dorello canal. So any pressure will stretch the nerve and causing what we call false localizing sign, because you don't know what happened exactly in the brain. And you have to consider that in your management. Case number 2, it's a lady, 21 years old, student, sudden crossing with diplopia since 1 day only before the visit. Her vision in right side was 20/25, left side was 20/100. So there is a change in vision, but with refraction, she has normal vision. She has also left esotropia with underaction of the lateral rectus muscle in the right and left gaze. And esotropia, when you measure it for distance, 18, for near, it's 9. So a major clue for decrease or incompetence and weakness of the lateral rectus that you have the patient showing some sort of divergence insufficiency. And with the examination of the fundus, the disc is edematous. And also OCT confirms that. So severe headache, incompetent esotropia, double vision, lateral optic disc swelling. Also, you need to go for MRI, which was normal. So the next step is to do lumbar puncture, see stepping to see the opening pressure, and refer to neurologist. They found that the pressure is high and started Sidamex for her to decrease the intracranial tension, and asked her to reduce weight. So this is another issue that you have to decrease the pressure and consider idiopathic intracranial hypertension in case of normal MRI. And you can see the serial pictures of the OCT shows improvement gradually until she became normal after nearly 1 month. This is the photos pre and post medication. So elevated intracranial pressure also will push on the nerve and cause a picture of abducens palsy. The same when the pressure is low after tabbing. It will also cause traction on the abducens nerve and cause the same picture. The same happens in children secondary to a variety of underlying causes like hydrocephalus, shunt failure, idiopathic intracranial hypertension, posterior tumor of posterior fossa tumors, venous sinus thrombosis, meningitis. All that will cause abducens palsy due to increase of pressure and tethering on the pulling on the abducens nerve. Case number 3 is a patient, 7 years old, diagnosed as a Duane syndrome left eye. But the parents said that she has always taking left face turn, but the deviation increased. Recently, when you examine the fundus, it's normal. This is the patient, and she shows fixation with the right eye, left esotropia in the primary position. She has decrease in abduction of -4, normal adduction of the left eye, normal ocular motility of the right eye. She takes always face turn, and she has very subtle retraction of the eye on adduction. This is her picture. You can see that she has left esotropia, the first turn to the left, and the defective abduction. When we did her MRI, it came abnormal, and she has a tumor in the brain. And also neoplastic case is a neoplastic cause for secondary cranial palsy should be considered when you examine the patient. Tumors account for about 20 to 45% of the sixth nerve in children, either the tumor itself or after surgery. And either it's a posterior fossa tumor or pontine glioma. So brainstem glioma is very common, and more than 80% arise in the bone. And onset is between 5 and 8 years of old, presenting also might include ataxia, disturbance of gait, unilateral or bilateral abducens nerve palsy. The location is very important to consider when you examine the child for sixth nerve palsy. You have to examine him as a whole, and you need definitely neurologist to examine him also. And as I said, if the tumor in the bones due to tumor, it might be accompanied by horizontal gaze palsy or facial nerve palsy, hemiparesis, hemisensory loss, ataxia, gait disturbance. Case number 4, also another child, 10 years old. She has urinary tract infection and fever, and she came with first turn. There is no history of trauma, and as you can see, she has also defective abduction of her left eye with esotropia. for distance 25% diopter, for near 16% diopter. So incompetence here is very indicative that there is something with the abduction. And when you examine the motility, there is left lateral rectus muscle under action -2. She takes the first turn to avoid double vision, and that's the picture showing the defect of the abduction -2 or -3. That's why she's taking the first turn. When you examine her chart, she came twice before the same condition. So the patient has 3 incidents of 6 nerve palsy, which is in this case post-viral infection and inflammation. So inflammatory and infectious disorder can cause abducens nerve palsy. Something called Gradenigo syndrome, when there is infection of the otitis media that causes inflammation Peters bone, where the abducens nerve is closely passing by it, can also cause 6 nerve palsy and facial pain. If you have 6 nerve palsy with other nerve pulses, it might be the infection of the cavernous sinus, which should be also managed properly. So the 6 nerve palsy, most common ocular motor paralysis in adult and second most common in children. And as I said, the patient should be investigated properly to find out what's the reason. The presence of incompetence during measurement of ESO deviation is very indicative that there is something wrong with the lateral rectus muscle. And in adults, most of the common causes is microvascular ischemia due to diabetes, hypertension, trauma, idiopathic, but there are other cases, other causes. I got patients with giant cell arteritis, multiple sclerosis, showing 6 nerve palsy. So in the prevalence of associated intracranial lesion, the American Academy recommends obtaining MRI for all children presenting with acquired 6 nerve palsy, even in absence of focal neurological findings. So when you have a patient with a benign 6 nerve palsy, you want to wait until he's recovered. So diplopia is very annoying, and you can help him with a prism. You can put patch or occluder of the glass. Sometimes you can use buttocks. But evaluation for surgery after 6 to 10 months of no improvement depends on the amount of residual function of that rectus muscle and presence of contraction of the medial rectus muscle. So when you evaluate, when you decide that this patient will need surgery, you have to evaluate the medial rectus and lateral rectus. If there is good function still of the lateral rectus muscle, you can do resection of the muscle accompanied by either buttocks injection of the medial rectus of the ipsilateral medial rectus or resection of the contralateral medial rectus. But if there is complete paralysis, at that time you need to do what we call transposition. We have various modalities of transposition, okay? And every surgeon prefers some technique. I prefer full tendon transposition with posterior technique. It gives me good results with the patients. But as I said, it's very important to evaluate the medial rectus before doing transposition, because if you have contractional medial rectus, it will definitely not give you a good result at the end. Thank you very much.
Thank you very much, Dr. Hassan, for this 6 nerve dish of salad. I think a mixture of etiologies, different etiologies of 6 nerve, but I'll keep my questions till the end for the sake of time. And I'd like to take your permission to start my presentation, please. I just want to make sure if you can see my presentation now or not.
No, sir, not yet.
Is it clear now?
You need to reshare your screen, sir.
Yes. I think you can see now.
Yes, sir.
Okay. So I will talk today about bridging the gap between orbit and strabismus, because in strabismus, most of the time we can see cases presenting with deviating eyes, but the main etiology is almost orbital. So orbital abnormalities account for a small proportion of patients with strabismus, but in cases of strabismus due to orbital disease, it's important to recognize the disorders for several reasons. First, it may be important to do systemic and visual assessment for any consequences of the orbital problem. Second, if we want to do imaging studies for orbital problem, and we should accustom our treatment plan according to the pathology of the orbit. So our main strategies and targets in evaluating strabismus with orbital problem is evaluation of progress, decision of intervention, and how to predict our prognosis of strabismus. So let's go for our first reason of joining or bridging the gap between strabismus and the orbit is to identify the orbital cause. Like in such patients with thyroid orbitopathy, these patients have thyroid eye disease, they come with evident strabismus in the primary position with deviating eyes and other pathologies. So it may come to treat orbital problem first or strabismus first. Then the strabismus can result from some cause of orbital fractures, like the lady on the left, coming after fracture, blew out fracture of the floor of the orbit of the right one, and left one came with traumatic picture of esotropia. So we have to differentiate, is it sixth nerve palsy or fracture medial wall of the orbit? Or other rare diagnosis is the torn lateral rectus. So it's very, very important to do imaging to differentiate between the causes so we can put our proper plan. Sometimes acquired Brown syndrome comes after orbital inflammatory disease, like this young lady coming with strabismus when she looks up and left after several attacks of orbital myositis, and she recorded some knee pain and rheumatological disorders. So before going for treatment of this strabismus, we should know the cause of orbital myositis and treat it properly if we can. Sometimes the orbital deformities, like this young girl with facial asymmetry. She has right exotropia, but for sure she has significant facial asymmetry that we can consider in treatment of our strabismus. Once more, we can find a different type of facial asymmetry in this lady coming with exotropia after recurrent attacks of deviating eyes, but she reported many strabismus surgeries. But before examination and treatment, we should know she has a deformity or facial symmetrical changes. After treating facial asymmetry, we can go for proper orthotropia after surgery, but without counseling that patient, she has previous deformity from the start, we can be in a mess of claiming or complaining patient. So how to assess extraocular muscle improvement with orbital disease? Usually we go through strabismus cases with orbital problems in our usual examination strategy, like examination in the primary position to assess our muscle balance. Is it coming with hypertropia, hypotropia, esotropia, or exotropia? This is first. And this will give us a short clue about the deviation in the primary position that we are mainly caring of. So we are just looking at manifest deviations, which is tropia, using Hirschberg test or corneal light reflex test, doing it properly to know the exact angle of deviation in the primary position. Then we can assess the angle, which gives us a clue of improvement or worsening of the orbital disease if we didn't start yet treatment of strabismus. So the angle assessment is not only for correction plan of strabismus, but we can consider in our treatment plan for orbital pathology before progressing to our strabismus surgery. One more parameter we should consider is the limitation of motility, because in orbital disease, usually we have limitation of motility and incompetence. So we have to assess the improvement or worsening of the limitation. Is it coming better or not? And for assessment of limitation of motility, you have to record it first, is it there or not? Then we have to measure it to consider the proper time to interfere with this limitation. Usually in concomitant strabismus, we use the prism bar to assess the proper angle of deviation of a strabismus using Kremesky test or Kremesky running prism bar test to assess the angle, and we can repeat it again using the modified Kremesky test, putting our prism bar on the other eye to know the difference between both tests. Typically in concomitant or comitant strabismus, they should be the same numbers. So using Kremesky and modified Kremesky test in assessment of the balance, we have to come out with equal numbers if we used Kremesky or modified Kremesky. This is not the case if we have orbital or concomitant strabismus for any reason, either extraocular muscle affection in paralytic strabismus or restrictive strabismus, or other restrictive causes of strabismus like orbital diseases of medial wall fractures or blue out fractures. If we used Kremesky test, we can measure the proper angle in this gentleman, but if we turn to the other eye using modified Kremesky, we'll find totally different numbers. Limitation can be calculated using usual ruler to see how many millimeters the eye can move. And there's a simple way of assessment of limitation of motility in our office. So we just keep the patient looking in the primary position, then we ask him to look at the maximal direction or the restricted direction, and we can measure how many millimeters he can maximally exert effort to move to. One more accurate type of measures is that Kestenbaum glasses. It's a graded glasses with that balanced watermark in the middle part of the glasses to see how many millimeters, because each line of the Kestenbaum glass equals about exactly 2 millimeters. So we can follow up our patients if he's undergoing treatment for thyroid eye disease, if he's taking injections or radiotherapy or systemic steroids, how many millimeters will improve or will be constant. In thyroid eye disease, it's very important to know the exact numbers he's improving, because we are searching for the Google guidelines that I will tell after a few slides, because one of the signs of improvement of thyroid orbitopathy is improvement of the movement of the eye, like this gentleman with thyroid eye disease. He has limitation of motility. One of the clues that can assess our improvement or worsening is using Hess screen, not for diagnosis of limitation, but just for grading his improving or not. And the very simple test, and I think it's available in many places, we can do a progressive assessment of ocular motility using Hess screen to know is it coming good or not. And we can again assess the secondary angle of improvement of the secondary angle after treatment of different strategies of thyroid eye disease in such patients. One more test is now available. I was trained upon this one in Germany maybe 4 years back, but they are using for a long time that test or Harms-Vent. It's combining the assessment of Hess screen with binocular sensory diplopia if the patient reported diplopia according to limitation, and they can correlate the diplopia measurement in relation to the limitation of actual motor motility, and it can compare his improving on both sensory and motor levels or not. Many publications came out, unfortunately not in English world, but in German and Sweden world, they are coming with new digital methods of assessment of binocular diplopia, improvement with Hess screen and Harms-Vent. Fortunately, we have now in Egypt this method of assessment so that we can follow our patients with thyroid eye disease if they are improving regarding diplopia or limitation or not. The way we do Harms screen is a very simple one. It takes about 20 minutes. And again, if we went for surgery for this patient, we can monitor our progression and improvement of the extraocular muscle motility, like this patient with his left eye limitation before doing surgery, and much improvement after doing strabismus surgery after going for the Lambert curve of inactive stage of thyroid eye disease. Then If he went through this Lambert curve, now he's fine for 1.5 years at least. He will not go for activity again, so we can operate. We can monitor our improvement not only clinically by limitation of motility improvement, but we can use our harms band and the screen to see how much it improved. One of the parameters recorded now in IGOGO of the European Group of Graves Ophthalmopathy Group, they came to put the limitation of motility, pain on movement of the eye, strabismus and primary vision as very, very precious clues in assessment of the scar scoring of the etiology before going for surgery and to monitor our improvement after giving the proper chance either preoperatively with steroids or intraorbital injections or after surgery after doing muscle recession. So how to assess extraocular improvement? We said identifying the cause, monitoring of improvement, and we can differentiate the paralytic from restrictive. It's very important to know because mostly after having orbital disease like fractures or thyroid eye disease or orbital inflammatory disease, we can have some restrictive component of the muscle as a consequence of this inflammation or fracture. So we should go for proper history taking and proper examination and imaging when needed. This case is having defective elevation of the right eye. It's defective in all directions, so it seems limited elevation of the right eye. So we can think about all causes of monocular elevation deficiency that may be deadly extraocular muscle affection because of fibrosis of the inferior rectus muscle, or maybe paralytic due to double elevator palsy, or maybe orbital if we have any history of trauma, such a case. But we are luckily having positive Bell's phenomena in such patient, and it's moving very well with forceful closure of the right eye. So there is no limitation or restriction, and it is a straightforward extraocular muscle case of double elevator palsy. So nothing to do with the orbit in such a case. Another lady came with, but now she came with history of trauma after a car accident. She came reporting right hypertropia, defective elevation of the right eye in all directions. And in this case, we should ask for imaging, not like the previous one. Imaging here demonstrated right orbital floor fracture. So we should refer this patient to orbital surgeon to correct for the orbital fracture first. Then we can deal with the hypertropia and the limitation. Another case with severe hypertropia, but now the patient is coming non-thyroid eye disease. So we should arrange our treatment plan and management according to endocrinological intervention and going for the steady Lambert curve. Then we can go for surgery after that to treat it after dealing with the orbital surgery. One more case of recurrent orbital myositis. She came with acquired Brown syndrome. She's a young dentist. She's reporting diplopia on looking up, and after going for rheumatological treatment and giving intraorbital steroid injection, and improvement occurred, but very limited elevation is there. Limitation of elevation and abduction. Then at that time, we can go for treatment of the limitation by doing surgery for the limitation by weakening of the superior oblique. Usually I do in Brown syndrome free tenectomy of the terminal fibers of superior oblique tendon. So it's very important to differentiate between the restrictive and paralytic causes of monocular elevation deficiency, because maybe straight paralytic double elevator palsy, maybe Brown syndrome, or congenital fibrosis syndrome, fracture of the floor, or thyroid eye disease. And we can sort out the cause starting first by force reduction test, or if we have Bell's phenomena, so it's clear double elevator palsy. If it's positive, if it's a limitation of doing force reduction test, or we don't have Bell's phenomena, we can think about other incompetent cases due to restriction, not due to paralysis. This is a case of a middle-aged man coming after aggressive surgery for treatment of orbital mass. It was a cavernous hemangioma, and he had severe proptosis. He went for many orbital surgeries, and he came again after finishing his orbital surgeries with this right hypertropia. And when I did force reduction test for him, it was very tight inferior rectus, and this is his picture after doing inferior rectus recession to relieve the effect. Thank you very much. This was the last talk, but it's open now for anyone of you if you want to ask any question regarding the topics. I remind you with our prestigious speakers, Dr. Delon, Dr. Hayat Khan, Dr. Hassan Sabri, and myself. If anyone of the audience wants to ask any question regarding our presentations.
I have a question for thyroid patients.
Yes, please.
If you have restriction for inferior rectus, for example, so do you go directly for the surgery or you just treat him medically first and then you plan your surgery?
Usually I wait for the Lambert curve, because if the patient, I am just following the guidelines of Igugu, they have the scar scoring. If the patient had a score of 3 or less, so now he's in the steady stage, so in a quiet stage. So if it's in active form, like then conjunctival hyperemia, pain on movement of his eyes, recurrent redness, changing the diplopia angle, changing the strabismus angle, changing limitation of motility on frequent visits, so I should never go for any intervention till he's in the Lambert curve. If he went through the Lambert curve, I'm sure if he had a score of 3 or less, now I'm quite sure he will never go through another attack before 1.5 years. So this is a proper time I can do my strabismus surgery.
So it takes time.
Yes. And it's very variable from one to another one, because it may take a few months, then may take years in some people.
Yep. You're absolutely right. Okay. Thank you.
Thank you. Dr. Hassan, I want to ask you again regarding sixth nerve palsy, because if you have a case is presented with neglected sixth nerve, so when you decide to do surgery for it and you found your force reduction test is positive, so it's quite evident we have contracture or limitation due to medial rectus contracture. Would you like to consider doing transposition surgery in whichever form, like Janssen or Hummelsheim or Nishida or any other transposition, and with the medial rectus recession, or you start with medial rectus recession first, then you consider transposition in a second intervention?
Actually, I didn't face such a problem before because I always don't wait for a long time for a patient to be neglected. If I decide to do surgery after 12 months from his incidence of sixth nerve palsy, I try to let him avoid contraction of medial rectus. But I do prefer to treat the medial rectus contracture first. If I have a chance to give Botox, I give the Botox injection and see how much the lateral rectus will move, because sometimes contracture itself will give you a false appearance of severe lateral rectus weakness and abducens palsy. So treat contracture first with Botox or recession, and then manage transposition as a second stage. I do prefer that. Okay, thank you very much. I'd like to ask Dr. Hayat Khan for using atropine in the dose of 0.01 or 0.1. Do you monitor in your cases the cycloplegic effect? Because usually it's written in literature, the 0.01 or 0.1 is a non-cycloplegic concentration of atropine. So do you face any patients complaining of accommodation problem after using this low concentration of atropine or not? Dr. Hayat, busy.
Okay, so I don't think he is with us now. So any other one of the audience wants to ask any question?
So do you use atropine 0.01 or what do you use?
Yes, I use 0.01, but actually I didn't face any patient complaining, but with 0.1, some patients complained of accommodation problems in my cases.
For how long?
Usually according to the patient, but usually it's not more than 1 year at least.
Would that be enough to stop the progression?
Yeah, usually I follow. Actually, very few cases I use with them, but most patients go around doctors. So many of them disappear.
Okay.
Dr. Sameh, if you don't mind, we can conclude. You're already 10 minutes over the session.
Okay.
Thank you very much.
The conclusion.
Thank you for you, Dr. Sameh, Dr. Hassan, Dr. Hanover, and Dr. Hayat. Thanks for all of you. Thank you very much.
Thank you, Dr. Muhammad, and thank you for all the speakers. See you again
Thank
in other meetings.
Inshallah.
Inshallah. Thank you. Bye.